Once again, a big hello to all of you. So again, this is the third and the last part in the presentations of reflexes. That is the spinal reflexes. It is included in competency PY 10.2. Describe and discuss the functions and properties of synapse reflex receptors. So I'll not be repeating again and again that we have completed synapse receptors in previous classes. So reflexes in this presentation will be finishing the reflex part of the CNS. Now, as you know that whatever we learn, we should be very clear that what we want to learn in a thing, what we should know about a particular topic. So again, the specific learning objectives. So as we say at the end of the session, the students should be able to, but this session of reflexes has been divided into 3 sessions. So this is the third and the last sessions, but I'll be again repeating those objectives. Now I assume that in the end of this session, you will be able to learn all these specific learning objectives, starting from the first one, that is define reflex and outline the components of reflex are clearly. So now you should be very clear what is a reflex and what are the components of reflex are. Then second one, differentiate between monosynaptic and polysynaptic reflexes appropriately. So in this particular session, we'll be taking up this learning objective. The next one, enumerate different spinal reflexes. That is, you should have on your tips what are the different spinal reflexes, the classification we have talked, and what are the different types of reflexes and the different types of classifications. Then explain the physiological basis of stretch reflex and describe it in detail accurately. Now you should be very clear in the mind that how the stretch reflex is elicited, what is the background behind it, what leads to its stimulation, and what is the response, and why do we need this. So this becomes very, very important. The objective that explain different spinal reflexes with their physiological basis correctly. We are now very much clear about it, that what are the different reflexes, spinal reflexes, and what is the basic mechanism behind these reflexes. I expect you all to know this. Then next one, describe the role and structure of muscle spindle and Golgi tendon organ appropriately. So we have discussed in detail what is muscle spindle, what is Golgi tendon organ, and we have discussed in detail how they function, what stimuli leads to their excitation and how they are controlled and how do they respond, and what are the different reflexes like stretch reflex, inverse stretch reflex, in which they part. The objective, explain the alpha gamma motor neuron linkage. We know that because of this there is a proper smoothing of muscle contraction going on. Then give the role of higher centers in control of spinal reflexes accurately. Some I have been talking about in my previous 2 sessions about this, not separately but along with the reflexes. I'll be talking today only also in this session. Clearly describe the properties of spinal reflexes. We discussed all the properties of spinal reflexes in the previous presentations, like recruitment, local sign, occlusion, etc, etc, etc. Then lastly, explain the abnormalities associated with spinal reflexes. Spinal reflexes have multiple abnormalities associated, so different conditions in which they become abnormal. So we will be taking some of the abnormalities, discussing the clinical classification of the spinal reflexes. So in this clinical classification, we'll be discussing the superficial and deep reflexes, the pathological classification, visceral reflexes in short, and then we'll be discussing the difference between upper and lower motor neuron lesions, and then certain other abnormalities in short. and why do we need these spinal reflexes, and then finally we will summarize the spinal reflexes. I'll not going into detail of the spinal reflexes, how do they elicit, because most of this is a practical aspect which is covered in another practical part. Then we will be discussing mainly the clinical classification here and the abnormalities associated with spinal reflexes. Some of the abnormalities we will also be taking up when we discuss the abnormalities of the spinal cord. Difference between monosynaptic and polysynaptic spinal reflexes should be very clearly understood, so that we understand the mechanism of the body, the posture, how do you maintain your tone, how you protect yourself, and how you walk, how you run. So this difference should be very much clearly understood. Now we have monosynaptic spinal reflex is the only monosynaptic spinal reflex is the stretch reflex. While we have multiple polysynaptic spinal reflexes, here we are going to study the difference between stretch reflex and flexor withdrawal reflex. Stretch reflex, it's a monosynaptic reflex, and flexor withdrawal reflex is a polysynaptic reflex involving multiple synapses. So the receptors at the stretch reflex is because of stimulation of muscle spindles present in the belly of the muscle, while flexor withdrawal reflex is initiated because of stimulation of the painful receptors, the nociceptors. The afferents involved in the stretch reflex are the angulospiral endings or the group 1A fibers, which has the highest velocity, that is up to 120 meters per second, and of the largest diameter up to 20 micron. They are myelinated fibers. While the afferents for flexor withdrawal reflex are collectively called as flexor reflex afferents, FRA, they are group 2, group 3 and group 4 fibers of sensory classification. They have comparatively lesser velocity and of a smaller diameter. Whenever a stretch reflex is initiated, the muscle in which the muscle spindle is present, it is stimulated and its antagonistic muscle is inhibited, that is, there is muscle is flexed and the extensor is inhibited. In the case of flexor withdrawal reflex, suppose your right foot suddenly is placed on a broken glass, and the flexor withdrawal reflex is stimulated because of stimulation of nociceptors. So what will happen? Immediately you will lift your right knee. So there is flexion of the same side, while there will be extension of the opposite side. Your left leg is going to extend so that your body weight is being supported on the left leg, otherwise you may fall down, and the extensor of the right leg, it will be inhibited because you want to flex your knee and put it away from the broken glass, and the flexor of the opposite side, that is of the left side, will be inhibited because you want your left leg to extend, not to flex, so that your whole body weight is supported on the left leg. Divergence is very less or almost negligible in the stretch reflex, as there is involvement of only one synapse for the same muscle and another for the antagonistic muscle. Flexor withdrawal reflex shows large divergence as there are numerous neurons involved here. The stretch reflex, as it has only one synapse, so the central reflex time is less, so there is no synaptic delay. Synaptic delay is only of one neuron, one synapse, so the total reflex time is less. As the central reflex time is less, so latency is less, so it's a very fast reflex. In the case of flexor withdrawal reflex, as it is a polysynaptic reflex, so in the spinal cord there are multiple synapses involved. This leads to a longer central reflex time. So whenever there is a longer central reflex time, So what will be the result? Result is that the total reflex time is longer. So the latency will be longer as the time taken by the impulse to reach from the receptor to the spinal cord and the response to be generated in the effector muscle is long. Although the flexor withdrawal reflex is a very fast reflex, but when we compare with the stretch reflex, it becomes longer. The stretch reflex is required for tone, for posture, while the flexor withdrawal reflex, it's a prepotent reflex. It's a protective reflex. It plays some role in the posture also, but mainly it is a protective reflex. It protects you against different noxious stimuli or injuries, or try to protect the body. The other protective polysynaptic reflexes are the corneal reflex, the lacrimal reflex, the coughing and the sneezing reflex. Then there are other polysynaptic spinal reflexes which are involved in multiple processes of your body, like those involved in nutrition are swallowing reflex, sucking, then deglutition, that is swallowing mainly. Then the locomotor reflexes will help you in locomotion, in walking, in moving. Then autonomic reflexes. Autonomic reflexes are very important. They are polysynaptic reflexes, and one of the arc is belonging to the autonomic nervous system. The duration of stretch reflex is shorter as total reflex time is shorter. So duration is shorter, while flexor withdrawal reflex, it's a long duration as multiple neurons are involved. The central reflex time is longer, so the total reflex time is longer. The properties seen in multiple spinal reflexes, like after discharge, local sign and recruitment, is not seen in the case of stretch reflex, while it is definitely seen in the case of flexor withdrawal reflex. That is the reason, even if you remove your foot or your hand from the pin which is pricking you, still you feel outlasting pain, and its duration is longer. Then local sign that you remove your hand from that pin prick, and as the stimulus is stronger, more and more neurons will be involved. Another very important classification is clinical classification, or what we called as clinical reflexes. Why this becomes very important? Because reflex testing is a powerful clinical tool. So whenever clinically we are testing the reflexes, we apply the stimulus, we see the response. Suppose we find an absent response, that is there is no response at all. Now what we do, we try to find out where and why the reflex is not being elicited. That maybe the pathway is interrupted, either the afferent pathway or in the spinal cord or the efferent pathway. Then instead of the reflexes being absent, the reflexes show an abnormal response. Now what we try to do, the clinicians try to locate where exactly the pathway could have been compromised, and then he can detect or diagnose the condition or diagnose the disease and treat the patient accordingly. According to the clinical classification, or clinically, the reflexes can be classified into physiological reflexes and pathological reflexes. Physiologically, the reflexes are of three types: superficial reflexes, deep reflexes, and visceral reflexes. While pathologically, we have multiple pathological reflexes or signs, but I'll be concentrating only few which is important, and next other physiological reflexes you'll be reading while you go in your subsequent batches of MBBS. So we have in this Babinski sign, Mars reflex, Clonus, and Pendular reflexes. The superficial reflexes, they are initiated by tactile stimulation of superficial structures of the body like skin or mucous membrane. That is why the name has been given the superficial reflexes. So this tactile stimulation can be scratching, stroking, or pinching, or any knocker stimulus also. although the stimulus is being applied to the superficial structures, but the response is the motor responses. Response comes from the muscles as a motor response. Exception to this is the pupillary reflex, in which we throw light on the pupils. We do not scratch or stroke the pupil and we get the response. The superficial reflexes, they are polysynaptic reflexes. They are polysynaptic reflexes and they form the they are other protective reflexes themselves, and or they are modification of those protective reflexes. Stimulus is generally nociceptive, that is a painful stimulus is required to be implicated. The pain not necessarily is to be applied on the skin. Nociceptive stimulation of the deeper structure does also suffice. They may also fulfill the criteria of stimulus. The exact group of the muscles involved and the severity of their contraction depends upon the local sign or the efferent input, that is the site and the number of the receptors stimulated. Superficial reflexes which are studied in the healthy adults are not exactly or purely the withdrawal reflexes, but they result from the activity of the spinal cord as guided by and modified by the higher centers. As we can see here that the afferents, they come from the superficial receptors, they travel in the dorsal horn, reach the spinal cord, first order or second order neurons, they travel in the posterior column tracts of gall and burdock and also in the spinothalamic tracts and then they reach the higher centers. The center can be thalamus, midbrain or cerebral cortex, or they go via the thalamus or midbrain to the cerebral cortex. Then the efferents responsible for the effector muscles are the descending tracts, that is corticospinal tract, and the extrapyramidal tract, that is corticospinal tract also known as pyramidal tract, and then the extrapyramidal tract. These tracts then they rely on the anterior horn cells of the muscle and thus the response is being produced. So as a consequence, what we see is that not only a sensory interruption but also an interruption in the descending pathway from the upper motor neuron to the lower motor neuron can cause either diminution or abolition or modification of the superficial reflexes. And while eliciting superficial reflexes, we need to keep in picture certain important points of the reflexes, which also applies to the deep reflexes but more important for the superficial reflexes. First is the nature of the stimulus. Nature of the stimulus. Though most of the superficial reflexes are originally flexor or withdrawal reflexes, it is not always necessary to apply a nociceptive stimulus in every case. If the reflexes is not obtained, only then we need to increase the pressure or pain may be used. Then the size of the receptive area, that is the receptive field on which we are applying the stimulus. More the larger the receptive field of the skin, more stimulation and the response is the better. Then thirdly, location of the receptive field. In many cases, the same response may be elicited by stimulation of different areas. So this is location of the receptive field is also important. Then lastly, weakness of the reflexes. Very often repeated stimulation is required before we get required response. In general, these reflexes respond slowly, their latent period is long and they fatigue very easily. So absence of a superficial reflex doesn't give you a sign of a disease, but its alteration is. So if sometimes when the reflexes, we are not able to elicit the reflexes, we need to increase the size of the receptive field and then we can increase the pressure of the stimulus to elicit the response. The superficial reflexes can further be of two types, either the cutaneous reflexes or the mucous membrane reflexes. This classification is based on that where is the stimulating focus. So if it is the stimulating receptive field is the skin, we call them cutaneous reflexes. When it is mucous membrane, we call them the mucous membrane reflexes. So accordingly, The cutaneous reflexes are of different types. What we generally elicit clinically are plantar reflex, elicited from the plantar area of the foot, then abdominal reflex elicited from the abdominal muscles, then scapular reflex from the scapula, cremastic reflex from the cremastic muscle. The other two cutaneous reflexes are anal reflex, what we call as anal wink, and bulbocavernous reflex, which is elicited from the bulbocavernous muscle. The mucous membrane reflexes are corneal reflex elicited from cornea, conjunctival reflex from the conjunctiva. These two reflexes protect the eye. Pharyngeal and gag reflex is seen in the pharynx, and that is why you we gag whenever anything enters our pharynx. Then palatal reflex, it's also very protective reflex. Then the last one is the pupillary reflex, which has light reflex and accommodation reflex. Some physiologists take up the pupillary reflexes as a visceral reflex, as the autonomic nervous system is also involved, but here we have taken up this into superficial reflexes as mucous membrane reflex. In this presentation, I will not be discussing the superficial reflexes in detail, that how do we elicit them, what is the root value, what is the center, and what is the response, because this comes in the clinical part and clinical or the practical part, which has to be taken up separately in other presentations and lectures. So I'll be just giving you the names of superficial reflexes and abnormalities associated with the superficial reflexes. The second type of clinical reflexes are deep reflexes. They are deep jerks or tendon reflexes. They are elicited from the deeper structures. They are examples of phasic stretch reflexes. They provide information about the integrity of central nervous system and peripheral nervous system. So we elicit these reflexes and we try to see the integrity of CNS, that if the afferents are normal or the efferents are normal or the spinal cord is normal. There are different type of deep tendon reflexes which are clinically tested to see the integrity of CNS and peripheral nervous system. We have the knee jerk, ankle jerk, triceps jerk, biceps jerk, supinator jerk, the jaw jerk. The name itself tells us that from where exactly the reflexes, deep tendon reflexes are elicited, like knee jerk from knee, ankle from ankle, triceps from the triceps muscle, biceps from the biceps, and as accordingly supinator jerk and the jaw jerk. Now the basic mechanism of eliciting the reflexes, that how the deep tendon reflexes are elicited. I'll not be giving you the more details that how the different reflexes are elicited. I'll be talking of only one reflex, that is the knee jerk reflex or the knee reflex, knee jerk reflex, or this deep tendon reflex in which knee is involved. So when we take a hammer and tap the patellar tendon, that is a quadriceps femoris tendon is tapped here. Suddenly these legs are kept in the this position, and then we tap the quadriceps femoris tendon. When we tap the tendon, this is going to stretch the muscle. This is going to stretch the quadriceps femoris muscle. When the quadriceps femoris muscle is stretched, in it is present the muscle spindle. The muscle spindle are also stretched. They send the impulses via the annulospiral ending or the group 1A fibers through the dorsal root ganglion, to the dorsal root ganglion, and then they enter the anterior horn and relay in the anterior horn muscle, or the muscle anterior horn which supplies the quadriceps femoris muscle. If you see this muscle, the efferent, they travel to the muscle, and then the extrafusal muscle fibers are stimulated, and the knee immediately it the jerks forward. This is the response, that is the contraction of the muscle, and it relieves the stretch. Side by side, we can see that here the impulses also go to an interneuron, which is an inhibitory interneuron, and this interneuron, it inhibits the antagonistic muscle, and the efferents go to the antagonistic muscle. It is inhibited. The antagonistic muscle here, it relaxes instead of contracting. So whenever we strike the patellar tendon or quadriceps femoris tendon, the response is the jerking forward of the leg or your knee, and this is the positive knee jerk. Similarly, response can also be obtained by striking the belly of the muscle itself. That is, you suddenly belly of the muscle, sudden stretch of the muscle spindle will also occur. That is all that is required. What you require is to elicit a stretch reflex. Basically, you want to stretch the muscle to stimulate the muscle spindle. You can also elicit the triceps jerk by tapping on the tendon of triceps brachii, causing an extensor response at the elbow, and as a result of contraction of the triceps muscle. Then we tap on the Achilles tendon, it will cause an ankle jerk due to reflex contraction of the gastrocnemius muscle, and tapping on the side of the face causes the stretch reflex in the masseter or the jaw reflex. So different reflexes can be elicited in this way. So these deep tendon reflexes, they are the phasic stretch reflexes. While studying the deep tendon reflexes or while testing the deep tendon reflexes, we have to keep certain points in mind. First of all, we should be very clear that the receptors are not the tendon of the muscle. Then what are the receptors? Receptors we know is muscle spindle. So what the tendons do? Tendons, they act as a lever to activate the muscle spindle, which discharges and sends impulses to alpha motor neuron to cause the muscle contraction. The second very important point is that these deep reflexes are controlled at the spinal cord level. We know that, we are clear about that, but then they are also being modified or controlled by the higher centers like the facilitatory and inhibitory reticular formation, which are further being controlled by the other higher centers. So thus these reflexes can be modified this way. Normally what happens? Normally whatever discharge comes from the upper motor neurons, that is from higher centers, to the lower motor neuron. Which are the lower motor neurons here? They are the alpha and gamma motor neuron as well as the cranial nerve nuclei. The discharge is slightly inhibitory. So they try to control the lower motor neuron. They don't let them to be hyperactive in the normal circumstances. We are talking of normal circumstances. Then what happens when there is any lesion of the upper motor neurons, or there is any interruption between the pathway between the upper motor neuron and the lower motor neuron? So what will happen? When there is interruption or when there is destruction, no impulses are going to reach the lower motor neuron. Here we are talking of alpha and gamma motor neuron. So what will happen? When you are not being inhibited, what will happen? No inhibition, their sensitivity increases, their activity increases, and what we get? In result, what we get is, we get the exaggerated deep tendon reflexes. So now we are clear that whenever there is any lesion of the upper motor neuron or there is any interruption above the lower motor neuron, that is connection between the upper and the lower motor neuron, the resultant reflexes will be exaggerated, that is exaggerated deep tendon reflexes. The second condition is the lesion of the lower motor neuron. So if there is a lesion of the lower motor neuron or there is interruption or degeneration or any injury to the pathway of the pathway of the reflex are, that is the impulses being carried from muscle spindle via the dorsal root to the spinal cord, or from the spinal cord to the muscle, there will be no tendon reflexes. That is, the tendon reflexes completely are absent. So now we know that why do the neurologists, they test reflexes. They test reflexes, or the deep tendon reflexes are tested by the neurologist to measure the presence and strength of a number of reflexes. That is, all the reflexes are to be tested and their grading is done, which you will be studying in your clinical classes, classes of during the practical classes. And secondly, they need to assess the integrity of the nerve circuits involved. If they can easily find where is the interruption lies, and then they can assess the degree of facilitation of spinal cord centers. That is, how the higher centers are facilitating the spinal cord centers, and by checking the deep tendon reflex.
These pictures show the elicitation of different deep tendon reflexes. This is the Pendular or knee jerk. The patella being struck, or the tendon just below the patella is being struck, and then the response is the extension of the forward jerking of the knee. This can be done when the legs are lying down, the legs are hanging from the couch or the bed, or it can be done in the lying down position also. Then the triceps jerk. Here the arm of the subject is being supported by the examiner, and then he is striking the tendon of the triceps, and then the arm is kept in a flexed position and being supported by the hand of the examiner, and then suddenly when the examiner taps on it, the response will be in the form of extension by the triceps muscle present over here. Then Achilles reflex or the plantar reflexes. Here it can be generally elicited when the patient is lying down. It can be done in the hanging down position also. Here the tendon of the Achilles tendon or the tendon of the gastrocnemius muscle is struck. When it is struck, and then immediately the reflex response is in the form of the ankle jerk. It is in the form of the responses generated. Bending of the ankle is there. Then the biceps jerk. In the biceps jerk, the hand is again being supported by the examiner's arm, and here the biceps tendon is very delicate, so it is not directly being struck by, but it is being struck by the examiner's thumb, and then it is struck, and then the response will be in the form of flexion. Then brachioradialis reflex or the supinator reflex, or here the hand is arm is kept in a semi-prone position, and then the tendon of the brachioradialis is struck here, and then the response is in the case of the supination of the arm. It is in the, these are the few reflexes, few tendon jerk reflexes. You'll be doing it in detail yourself, doing in your clinical classes and the practical classes, and seeing the response yourself and grading the reflex. After a neurophysiologist or a physiologist or a clinician has tested the deep tendon reflexes clinically, now the response is expressed in the forms of the grading of the reflexes. That is, we grade the result of the deep tendon reflexes or the response of the deep tendon reflexes into different grades. They extend from 0 to 4. Sometimes grade 5 is also there. So we say grade 0 when we don't get any response. That is, the reflex response is completely absent, no response at all. Then if the response is present, like a normal ankle jerk, that is, ankle jerk is normally elicited. If there are normal responses of all the reflexes in this such a manner, we call it as grade 1+. Then if the reflexes response is brisk, like a normal knee jerk, because if you compare a normal knee jerk and a normal ankle jerk, comparatively knee jerk is brisk. So grade 2 is, when we say brisk, it is as a normal knee jerk. It is also considered somewhat normal. Then grade 3+, when the response is very brisk, we called it as grade 3+ response. Then grade 4 plus when there is a presence of clonus, that is repeated jerky movements. Some uh, clinicians, they grade they have another grade which is grade 5 plus. How they differentiate between grade 4 and grade 5? They say in grade 4 the clonus is unsustained, that is it remains for shorter time, it is not sustained for longer time. We will try to elicit the clonus, while when the clonus becomes sustained, it is called as grade 5 plus. So clonus is basically repeated jerky movements of the tendon. So it is very brisk sort of tendon reflex. So this is about the grading of the deep tendon reflexes, which you yourself will be doing clinically in your practical classes or your clinical laboratories. The tendon reflexes can be decreased or absent. So when they are decreased, we say that there is hyporeflexia, or when they are absent, we say that areflexia. So what are the reasons behind this hyporeflexia or areflexia? Physiologically also, sometimes you get decreased responses or hyperreflexia. Then what you need to do is you require reinforcement, what we call Jendrassik's maneuver or other reinforcement maneuvers to reinforce the response. So we can elicit the responses, and then there will be no hyporeflexia. Or pathologically, there can be lesions of the lower motor neurons, that is the neurons which of spinal cord, alpha and gamma neurons, or the cranial nerves. So any lesion involving the afferent pathway of the reflex arc, like seen in the case of tabes dorsalis due to syphilis. So what will happen here? When the afferent pathway is interrupted, no impulses are going to reach the spinal cord, so there will be absent reflexes, or there can be lesions of the anterior horn cells. That is the anterior horn cells which sends the efferent are themselves disrupted due to any disease. For example, poliomyelitis, or efferent pathways are disrupted due to any trauma, any tumor, or any obstruction in the pathway, or due to any sclerotic diseases. So in this case, their reflexes will be absent, or both afferent and efferent pathways are affected. Like this is seen in the peripheral neuropathies, or when there are peripheral nerve injuries. In this case, both the afferent and efferent pathways can be affected. So in these conditions, there is generally the unilateral loss of the reflexes. The reflex loss is also seen in the case of spinal shock, whenever there is injury to the spinal cord. Whenever there is injury to the spinal cord, the reflexes, all the motor and sensory reflexes below the level of the injury are lost, or below the site of the lesion are lost for some time, and it depends upon the recovery from the spinal shock. As the person recovers from the spinal shock, then the reflexes may come back to normal, or they give a different response, which we'll be studying out in different lecture. Then the reflexes can be bilaterally lost in coma. So coma due to coma, any coma in which the sensorium is lost or depressed, in that cases, due to any reason, whenever coma is there, the reflexes are lost. In case of myxedema or hypothyroidism, we get a prolonged reflex time, as both the contraction and relaxation phases of the tendon reflex may be prolonged. So sometimes this is also called as myotonic reflex in these cases. Similar findings also be there in the hypothermic patients. Then uh, there can be increased or exaggerated reflexes, what we call hyperreflexia. This can physiologically be seen in the case of anxiety or nervousness. So physiologically seen in the case of anxiety and nervousness. When you are anxious or nervous, you may show exaggerated responses. And then also seen in upper motor neuron lesion. that is the neurons other than the alpha, gamma and cranial nerve nuclei, the neurons of the cerebral cortex or of the extrapyramidal system. Here also, if there is any disruption, this can lead to exaggerated reflex because the inhibitory control is lost, as we said earlier. Then in the case of thyrotoxicosis also, we get exaggerated reflex or hyperreflexia, and in tetanus also sometimes we see the hyperreflexia. Now we have to think before labeling a patient abnormal, because if the reflexes are exaggerated and especially they are asymmetrical and their associated findings, then only we should consider them as pathological response.
Visceral reflexes is another type of reflexes which is included in the clinical classification. Why do we call them visceral reflexes? The name itself suggests that they are elicited from viscera, and the reflexes are mediated by autonomic nerves. At least one part of the reflex arc is formed by autonomic nerves. The visceral reflexes are the most ancient cognitive mechanisms which are present in the human body. That is, they are one of the primitive reflexes which are present in the human body. They are unconscious, automatic responses to stimulation, like the somatic reflexes. But here, instead of the somatic receptors, we have the visceral receptors, and the effectors somewhat take more time to respond. So the visceral reflexes are slightly slower if we compare them with the somatic reflexes. Now, there are multiple segmental autonomic reflexes in the spinal cord. That is why in a spinal animal, we can study the visceral reflexes also. These reflexes are important to maintain the homeostasis. What is homeostasis? This is the maintenance of constancy of the internal environment. So these reflexes, they regulate internal processes such as digestion and many multiple processes. For example, one of them is maintaining the function of the liver. So collectively they manage the maintenance of homeostasis. So homeostasis is maintained with the help of these visceral reflexes. Now we are clear that why visceral reflexes are important to maintain the homeostasis. Now there are multiple visceral reflexes. I will just name a few. Baroreceptor reflex, which regulates blood pressure and indirectly heart rate also. Micturition reflex, responsible for evacuation of bladder. Then defecation reflex, responsible for uh, evacuation of bowel, and many other like changes in the vascular tone due to local skin heat and cold. So whenever there is any body part or skin is exposed to hot temperature or cold temperature, there are changes in the vascular tone. Then sweating due to localized heat. Why do you sweat? When there is localized heat or the body temperature, again this is one of the visceral reflexes. Then intestinal reflexes, which help us regulate the intake and output of the GIT. Then peritoneal-intestinal reflexes. So we have multiple reflexes which are included in these visceral reflexes. The autonomic activity, it revolves around a visceral arc that includes receptors, then efferents, a center and an efferent. Receptors can be nerve endings which detect stretch, like the baroreceptors, they detect the stretch in the vessel wall due to the pressure changes. Then tissue damage, alteration in blood chemicals, what we called as chemoreceptors, then body temperature, the thermoreceptors, and many other internal stimuli. Then these receptors sense the changes, and then afferents, they enter the CNS, they lead to the CNS. In the CNS, the afferents are present in the different thoracic segments, in the spinal segments, in the lumbar segments, and in the medulla and the pons midbrain, that is the cranial part, and also the interneurons in the CNS. From here, then impulses, they are integrated, and then impulses pass by the from the CNS to the effectors. Effectors can be any visceral organs, like they can be glands, smooth muscles, etc. So the reflex arc is same: receptors, efferents, a center, efferents, and the effector. But the type of the receptors are different, type of the efferents and efferents are different, and type of the center is different. Let us see this visceral reflex arc. Here the stimulus is that it can be a tissue damage, an alteration in blood chemicals, anything. So the stimulus, it goes through these sensory via it's received by the sensory receptors in the viscera. The afferent nerves, they enter the, like other spinal nerves, they enter the dorsal root by the dorsal root ganglion, and then they can land up in the intermediate lateral horn, in the thoracolumbar segment, and in the sacral segment, and in the cranial nerve nuclei. Then the efferents, they come out as preganglionic neuron. Then preganglionic efferents, they can land up in a ganglion. So ganglion can be lying in the brain, in the brain, or that, or they can be along the spinal cord in the paraganglionic chain or the preganglionic chain, or near the organ or in the organ itself. Then postganglionic fibers, which are basically the visceral efferents, they go and then relay in the viscera and produce a response. Response can be in the form of peristalsis or change in the blood pressure, or many different sort of the changes which affect the homeostasis. Now the pathological reflexes, coming to the pathological reflexes. So in the pathological reflexes, there are multiple abnormal reflexes, but we'll be taking up only few which are important here. Most of them you'll be studying as you go through your clinical postings and through your medicine classes. First of all, let us take a very important sign, which is the Babinski sign, or what we called as extensor plantar response. The other name is Babinski extensor plantar response, or Babinski sign positive, or simply as Babinski sign. Why do we call it a Babinski? Because the Babinski was the scientist or the physiologist who first of all detected this, and the name was given Babinski sign. So Babinski sign is very important because assessment of plantar reflex is of great clinical importance. It is an objective response. It is an objective response which easily can be compared by various observers. So it's not a subjective response, it's an objective response that you elicit, you see a particular type of response, so anybody can elicit and compare it. So here we get an abnormal plantar reflex. Instead of the normal plantar reflex, we get an abnormal plantar reflex. What is it? Plantar reflex is one of the superficial reflexes. It is elicited while we strike with the we strike or with the help of a blunt object or the blunt side of the hammer. So the stimulus starts from the lateral side of the sole, moving towards the base of the toes. So and at the base of the toe, then we turn medially to the end of the, and it ends at the base of the great toe. The response which we get in the form of the plantar flexion of the great toe and adduction and plantar flexion of the other toe is known as the plantar reflex response. We say that the plantar reflex is positive. So here they have written Babinski negative. We don't have any term as Babinski negative. Rather, we should say it is a normal plantar reflex. But when there is abnormality, when there is generally upper motor neuron lesions, the reverse of this we get is known as Babinski's positive or Babinski sign. Here the way of stimulating the sole is same, that is moving from the lateral side medially ending at the base of the great toe, but the response which we get is different. So what type of response do we get? Here the great toe, it shows dorsiflexion fanning out, it shows dorsiflexion and fanning out, and the other toes also, they also fan out and show the dorsiflexion. So dorsiflexion of the great toe with fanning out and dorsiflexion of the other toes with abduction, and the dorsiflexion at the ankle and flexion at the knee and hip joint is the positive Babinski sign. This sign or this type of response can also be uh, received when we stimulate the other areas of the body part or the lower leg if the injury is very severe. So what are the other ways of getting this type of response of the great toe and the other toes is that if you start striking the shin from up to down, we get the same response. Then the sign is called as open hem sign instead of Babinski sign. Or when we pinch the calf muscles, we get the same response of the toes. This is known as Gordon sign. And then lastly, when we start striking from the lateral malleolus on the dorsum of the foot on the lateral side and then reach to the base of the toes. Here we are not striking the sole of the toe, but we are striking the dorsum of the toe, striking from the lateral malleolus to the lateral side of the foot till the base of the toes, and the response we get is the same dorsiflexion with fanning out of the toes, but the sign will be called the Chedok sign. So now we can have abnormal plantar reflex in the form of Babinski sign, in the form of open hem sign, Gordon sign, Chedok sign. So you will be able to elicit all these signs in your clinical classes, and you can see on your own how the plantar flexion response is there. This reflex which we have seen in the previous slides, if we see that this is controlled by corticospinal tract. How come? So there are basically two important pathways from the brain to the spinal cord, one belonging to the pyramidal system and other belonging to the extrapyramidal system. Pyramidal system or the pyramidal tract, what we called as corticospinal tract, see the neurons present in the cerebral cortex, which we'll be discussing in the later lectures. Then extrapyramidal system is all the part or all the non-cortical part which was present in earlier in the evolution. So what I mean to say is that the corticospinal tract or the pyramidal tract, they are newer in evolution. That is, as the telencephalization goes on, they are the last to develop. While the pyramidal tract, they are older in evolution. So the corticospinal tract will do what? Whatever reflexes are being controlled or the control of extrapyramidal tract is there, it will be superseded by the corticospinal tract. Like if we see the extrapyramidal system, it controls all the primitive reflexes of the spinal cord, like a animal crawling in the hole, the flexor withdrawal reflex, which is responsible for the removal of the hand from the painful stimuli. It is the function of the extrapyramidal system. So this Babinski response is the same as the flexor withdrawal reflex, like a primitive reflex. So the corticospinal tract has taken over and converted into a plantar flexor response, because we walk on our toes, walk on our feet. So whenever the child or a person, it keeps his foot on the ground, there is flexion to make a grip of the floor, and the person is propelled forward. So a grip is required. So the plantar reflex is maintained by the corticospinal tract. So whenever due to any reason this corticospinal tract is damaged, then what will happen? The depressed reflexes, the depressed primitive reflexes, that is, which is primitive, if here is the Babinski reflex, it will come in picture now. So due to any reason, any damage of corticospinal tract, the plantar flexor will be lost, and instead we get the primitive reflex Babinski sign. Now, what are the causes of this? As we said that whenever there is damage to the corticospinal tract, this Babinski sign is positive. So, any damage of upper motor neuron, that is the pyramidal neurons, or the neurons, or the path connection between the upper motor neurons and the lower motor neurons. So, this will lead to appearance of Babinski sign. Then, because in infants, when a child is born, his corticospinal tracts are not myelinated, myelination is still going on. So when it is not myelinated, the corticospinal tract do not have much of the control. So because of this reason, the child when born, when he starts walking, he still has a extensor response, rather physiologically has this Babinski sign. If we try to elicit the Babinski sign, it will be positive because it is physiological, it is normal, it's not abnormal. We have to take in consideration the age of the child also. But as the myelination progresses, the flexor response in the child, it starts appearing, and it appears beyond 12 to 18 months of age. So it means that if in an infant or in a toddler, the Babinski reflex is positive, in the age positive, we will not consider it abnormal. We will look the age of the child. If it is between 12 to 18 months, we will consider it normal because it starts developing by 12 to 18 months. Beyond 18 months, if it is there, we consider it normal. Now, this Babinski sign is sometimes seen in adolescents during deep sleep, generally up to 12 years. So why does it occur now? Because in deep sleep, in these children, in the cortex completely dissociates from the lower center because of the association tracts. So it also takes some time after they grow up. Again, this is not there. The other causes of Babinski sign are coma, deep coma or coma due to any reason. Whenever there is a coma, when there is depression of the conscious sensorium, then we can also elicit the Babinski sign. Even in the deep and general anesthesia, this can be elicited. In hypoglycemia, post-ictal stage of epilepsy, means after an episode of epilepsy, suddenly when we try to elicit the response, superficial plantar reflex, we get the Babinski reflex. Even during alcoholic intoxication, during head injury also, we can elicit the Babinski sign. Now there is another sign which we call as Hoffman sign. What is this Hoffman sign? If you see, there is clawing movement of fingers and thumb upon flicking the terminal phalanx of index or middle finger. This is also seen in hyperthyroidism and anxiety, and this is the same as Babinski reflex sign which we see in the lower limbs during the upper motor neuron lesion, but it is also seen in hyperthyroidism and anxiety. So how do we elicit it? We hold the index or the middle finger, and what we do, we flick the terminal phalanx just like this. We flick the terminal phalanx, flick, and we see the clawing movements of this thumb and this index finger. See, this thawing movement will be seen, thawing movement will be there. See, you flick over here, you flick over here, you hold the finger, flick over the terminal phalanx, you just flick, they come together, start coming together, flick, come together. This is the Hoffman sign. This is Hoffman sign. It is the same as Babinski sign, but this is seen in the upper limb rather than the lower limb. Sometimes in a spinal animal or human being, the spinal cord suddenly becomes excessively active, causing a massive discharge of large portions of the cord, leading to a widespread response. So this is called as mass reflex. What we called it? Mass reflex. I again repeat that in a spinal animal or a human being, when he has a spinal injury, sometimes the spinal cord suddenly becomes excessively active, causing a massive discharge of large portions of the cord, leading to a widespread response. This reflex can be elicited in patients with spinal cord lesion or a spinal animal, and this is generally seen even in the spinal injury during the recovery period of the spinal cord injury. This is seen. Stimulus is that the strong stimulation of skin with a nociceptive or even a non-nociceptive stimuli, like you scratch the inner aspect of the thigh or the lower abdominal wall, or even during over distension of the bladder and bowel, you can see this mass reflex. So any stimuli, you generally you strike the inside of the thigh or the lower abdominal wall, you will receive this response. So what is this mass reflex? What type of response do we get in this mass reflex? There is sudden flexion of the lower limb of the same side, and if the stimulus is in midline, then both the sides are affected, that is, both the lower limbs will suddenly go in flexion. There is also associated flexion of the anterior abdominal wall along with a sudden evacuation of bladder and bowel. And the arterial pressure can often increase to high values. Sometimes the systolic blood pressure can even go to 200 millimeters of mercury. Along with this, it has been seen that very large areas of the body below the lesion, they suddenly break out into profuse sweating, and generally there is associated bradycardia, but sometimes tachycardia can occur instead of bradycardia. So what response do we get in mass reflex? Whenever you strike inside of the thigh or there is over distension of the bladder and bowel, suddenly there is mass spread discharge of the spinal cord, leading to flexion of the lower limb with flexion of the anterior abdominal wall, with evacuation of bladder and bowel, and the arterial pressure shoots up with systolic pressure especially going high, going sometimes even beyond 200 millimeters of mercury, and the part of the body below the lesion, it suddenly starts sweating with sometimes bradycardia. So this what we call is the mass reflex, that is because multiple parts are discharging and we get a multiple response with a single stimulus. So what is the reason behind this? The reason is not precisely known, but because it is seen in generally during the recovery phase of the spinal cord injury patients or in a spinal animal. After recovery, the spinal motor neurons below the lesion become hypersensitive. What I mean to say is that whenever there is a spinal cord injury, the resting membrane potential of the spinal neurons, it goes below normal. But when during recovery, they become hypersensitive, and even a low threshold stimulus will lead to a better response. Moreover, there is increase in spinal neuronal irritability. So the hypersensitivity of the spinal motor neurons as well as the spinal neuronal irritability can lead to this response. Another reason is that there is activation of great masses of reverberating circuits that excite large areas of spinal cord at once, and moreover the spinal neurons are hypersensitive, there is spinal irritability along with this reverberating circuits. Larger masses of neurons in spinal cord are immediately or what we call simultaneously are stimulated, and this is similar to the mechanism of epileptic seizures that occur, that also involve reverberating circuits, but that occurs in the brain instead of the spinal cord, and this is occurring in the brain. So again repeat, the causes of mass reflex, which is the most probable cause of mass reflex, is the hypersensitive spinal neurons during recovery, spinal neuronal irritability along with the activation of great masses of reverberating circuits or reverberating neuronal circuits. So why we need to know this? Because we can use this in maintaining a spinal patient. So we can use him to train a patient for evacuation of bladder and bowel. How? We can ask him or his caretaker to scratch the inner side of the thigh whenever we want to evacuate the bladder and bowel, because it doesn't have a control on bladder and bowel. We scratch the inner side of the thigh and then there is evacuation of bladder and bowel, and this can be made useful. Clonus is one of the neurological signs generally seen in upper motor neuron lesion associated with hyperreflexia and hypertonia. Now, what is it? There is occurrence of involuntary, regular, jerky, rhythmic muscle contractions of agonist and antagonistic muscle when a muscle is subjected to a sudden maintained stretch. That is, when a muscle is stretched and that stretch is maintained for a long time. That is, you suddenly stretch a muscle and you keep that stretch for a long time. What you see in the muscle, there is contraction of alternately of the agonist and antagonistic muscle. So this clonus is ill sustained. It is ill sustained, leading to ill sustained jerky contractions compared with the technique contractions, in which there is prolonged sustained contractions. So if you where we can see this clonus you will not see in a normal person. So clonus is seen in all those conditions where there is increased gamma efferent activity, and then generally there is associated hyperreflexia and hypertonia. So these gamma efferents, they become highly sensitized. So because of this, they discharge is increased, and why the discharge is increased? Because in the normal circumstances, the lower motor neurons, they are kept inhibited. They are kept inhibited by the upper motor neurons via the interneurons. The upper motor neurons, they send impulses to the interneurons, and the interneurons, they partially inhibit the lower motor neurons. So once this upper motor neuron contact is lost, this can be lost whenever there is any upper motor neuron lesion, or the pathway connecting the lower motor neuron or upper motor neuron lesion is lost. So what will happen now? These lower motor neurons, like gamma efferent, motor neurons, they come out of their inhibition. When they come out of their inhibition, what happens is that interneurons are inhibited, because there is no stimulation to the interneurons which were inhibiting this gamma efferents. So the gamma efferents, they become hypersensitive, and whenever they become hypersensitive, when you try to stretch a muscle, such a muscle is stretched in which the gamma efferents are sensitive, they push a burst of impulses to the muscle. So this can be seen, clonus can be seen at ankle, at the patella and triceps muscle, in the wrist, in jaw, biceps, etc. So what you will see in these muscles, there is associated hyperreflexia and hypertonia, and most of the time the Babinski is also positive. Babinski is positive. So most of the time you elicit commonly the ankle clonus and patellar clonus or patellar clonus to confirm it. So whenever you try to see, if you see this person holding the foot of the subject or the patient, and then you suddenly dorsiflex the ankle, you support the foot with your hand, the other knee is being supported, and you suddenly dorsiflex the foot, what will happen? There will be a sudden stretch to the gastrocnemius muscle. When there is sudden stretch to the gastrocnemius muscle, this will do what? This will stimulate the muscle spindles, which are highly sensitized because of loss of inhibitory control. So these muscle spindles, via their gamma efferents, they will send burst of impulses to the muscle, that is the gastrocnemius muscle, and then it will cause the plantar flexion of the foot. Plantar flexion of the foot will occur, and when the foot goes down, you had dorsiflex, plantar flexion of the foot occurs, then the foot goes down. This will increase tension in the Golgi tendon organs of the gastrocnemius muscle via the group 1B fibers, which will now what do? Which will inhibit the contraction, and facilitate the contraction of antagonistic muscle, that is the tibialis anterior muscle, and now the dorsiflexion will occur. So you have dorsiflexed, the response is plantar flexion, and because it is now after plantar flexion, excess tension led to stimulation of Golgi tendon organ, the contraction of the gastrocnemius stopped, but the stimulation of antagonistic muscle, that is the tibialis anterior, occurred, and now the plantar flexion occur and the foot goes, dorsal flexion occur and the foot goes up, and this is inhibited, and then again because the stretch is maintained, again the same cycle goes on and on till the stretch is being maintained. So there is stretch reflex, inverse stretch reflex sequence. Even this can occur in absence of Golgi tendon organ also, when you are maintaining extreme stretch. Same way the patellar clonus can be elicited. What you do is you try to push the patella down with your hand in a patient of upper motor neuron lesion. Then what you will see that the patella will try to move up and down because of the clonus. So this is clonus. Now the clonus is generally seen in the ankle region. Generally we see the clonus in the ankle region. It has been seen that in the case of ankle clonus, the frequency of ankle clonus is generally between 5 to 8 Hz, and an average duration of an ankle clonus is about 160 to 200 millisecond. 45% of this is spent in flexion and 55% in dorsiflexion. That is, major portion is dorsiflexion and lesser comparable is plantar flexion. Now, first few oscillations are generally longer, then they become stable. After some time. There is another term called as unsustained clonus, or what we call as pseudo superius or exhaustible clonus. This is sometimes seen in a normal anxious individual or normal healthy individual, that we have 2 to 3 oscillations. In this we have only 2 to 3 oscillations, that is less than 5 to 8. So frequency is less as compared to the normal clonus. Normal clonus we also called as inexhaustible clonus. So in this, when such a type of clonus is seen, there will be plantar flexion, that is the Babinski sign will be absent, but in the case of the inexhaustible clonus, the Babinski sign will be positive, and generally there is associated hyperreflexia and hypertonia of the muscles with exaggerated reflexes are there. The causes of clonus is, why does the clonus occur? What is the reason behind the clonus? So any disease or any conditions which lead to the damage of upper motor neurons, or which damages the pathway between the upper motor neuron and the lower motor neuron, will lead to upper motor neuron lesion. There are multiple causes of this: multiple sclerosis, any spinal cord injury, tumors. So the multiple causes are there. So then also seen in the decerebrate animal. This clonus can also be seen in the decerebrate animal. Gendrasic's maneuver. This is a medical maneuver. Sometimes what happens that while you are eliciting the deep reflexes, even in a normal person, you are not able to elicit the deep reflexes, or the response is not appropriate. So what do? You try to reinforce the deep reflexes. How do you reinforce the deep reflexes? There is a maneuver called as Gendrasic's maneuver. So what you do in this, you try to pull the hands apart when the flexed fingers are hooked together, along with clenching of the teeth while you are eliciting the deep tendon reflex. I again repeat, you try to pull the patient tries to pull the hands apart when the flexed fingers are hooked together, and also there is clenching of teeth, and what you are doing, you are eliciting the side reflex. So you can see here the examiner is trying to elicit the deep tendon reflex, here is trying to elicit the knee jerk, and the patient or the subject, what is it he is doing? He has hooked both the hands together and the fingers are flexed. Now what he will try to do? you tell him to pull his hands apart while keeping the fingers, while keeping the hands locked. His hands are locked in flexion, and while kept in flexion, he is trying to pull apart his limbs, put apart his hands, and you are eliciting the knee jerk reflex. So this maneuver, and side by side the teeth are also clenched, which we cannot show in this picture, not shown in this picture, but clenching of teeth is also there. And when you try to elicit the tendon reflex, the reflex is elicited better. So you are reinforcing the tendon jerk reflex. So see, what is the benefit of this Gendrasix maneuver? I already told you that this will help in the reinforcement of tendon reflexes. So there is heightened deep tendon reflexes. So whenever you have a difficulty in eliciting a tendon reflex, you can use this maneuver, Gendrasix maneuver. The reason of this heightened deep tendon reflexes is there are multiple reasons given. One of the most probable reason and more appropriate reason is that the proprioceptive impulses from your hand and jaw. What you are doing? You have interlocked your hand, you have clenched your jaw. So what will happen? The proprioceptive impulses will go from your hand and also from jaw to activate the supraspinal centers. They will go to the spinal cord and they will activate the supraspinal centers, which supraspinal centers means that the neurons in the upper spinal cord, which in turn will lead to increase in gamma efferent discharge. How? By inhibiting the descending inhibition. So these impulses which go from your clenched hand or interlocked hand or clenched jaw, they will go to the spinal cord. So they become now supraspinal centers, because you are eliciting like knee jerk, you are eliciting your hand and this jaw neurons which are received by hand and jaw, they become supraspinal. They will carry impulses, and the higher motor neurons, they are sending impulses to the gamma efferent discharge. Gamma efferent neurons, they will try to inhibit the impulses from the higher centers, and the gamma efferent discharge will be slightly freed from the inhibition, and this leads to better response. So there is inhibiting of the descending inhibition. Who inhibits the descending inhibition? These supraspinal neurons, which you stimulated by interlocking your hands and clenching of the jaw. Secondly, also the help is there because you have not distracted the patient. So there is distraction of the patient, preventing the voluntary suppression of stretch reflex. Because sometimes what happens, that the patient is so tense that the response is not properly elicited. Now what you are trying to do is, you are trying to distract the patient, and if there is any voluntary suppression of the stretch reflex, that can be easily prevented. So the Gendrasix maneuver is commonly used in day-to-day practices whenever a neurophysiologist is examining or eliciting the reflexes, which you can also use in your clinical laboratory classes when you will be eliciting the reflexes. Sometimes what happens is that the knee tendon jerks are not brisk, but they show oscillations. So we call them the pendular reflexes. In the pendular reflexes, there is a knee jerk that swings forwards and backwards several times. So it becomes like a pendulum. Your knee becomes like a pendulum. You elicit a knee jerk in a normal brisk knee jerk, in a normal knee jerk or in a brisk knee jerk. What will happen when you try to elicit a knee jerk? There is little more than one swing forward and one swing backward. But here what happens, that you try to elicit the knee jerk, the knee swings forwards and backwards several times. So such type of reflex is called as the pendular reflex. Here the reflex jerks are showing oscillations and not the simple response backwards and forwards. This involves less dampening of the leaf movement than is usually observed, and this is generally seen in the cerebellar diseases. Cerebellar diseases, the pendular reflexes are seen in cerebellar diseases. They are manifestation of hypotonia and absence of restrictive effect. So cerebellum plays a role. We'll be studying the descending pathways. We'll be studying the cerebellum. We will see that how the cerebellum controls the spinal cord neurons. So we'll be studying that. So whenever there is cerebral disease, there is absence of that restrictive effect, and this leads to, there is hypotonia associated with it comparatively. So in this case, when you're trying to elicit a pendular reflexes are best observed when the patient's lower legs are allowed to hang and swing freely off at the end of the examining table. So when you're trying to elicit a knee jerk, what you do? You hang the patient's leg and try to elicit the knee jerk, and then if there are pendular reflexes, they are best seen in that case. So the pendular reflexes are seen in knee jerks, then cerebellar disease. Scratch reflex. This is a normal reflex. It is elicited whenever an interrupted, that is broken, not a linear sort of interrupted linear stimuli is applied to the skin, simulating the crawling of a flea or an insect, like when an insect crawls your skin. So it is an interrupted sort of stimuli, and this is initiated by itch and tickle sensation. So there are two functions of this, or two components of this scratch reflex. One is position sense for location of irritation, because it helps to locate exactly where is the point of irritation, where exactly the focus of stimulation is there. Because then the second is to and fro scratching movements, that is once the position sense, that is the point of irritation, has been located, now the hands will try to cause to and fro scratching movements of the hand, that is alternate contraction of the and relaxation of the alternate group of muscles to cause the reciprocal movements. Very interesting things about this reflex is that it exhibits three things: local sign, reciprocal inhibition, and rebound phenomena. What we see in the properties of spinal reflexes. Local sign is that limb on the same side of application, same side of stimulus application will respond. So if you give stimulus on right side of the body, your right forearm will make scratching movements. But when the stimulus side changes, the responding limb will also change. What I mean to say is that suppose your right sided body is stimulated, your right hand scratching tries to remove that irritation. Once that stimulus, like in this case we can imagine a stimulus is an insect, it crawls to the left side. Now what will happen now? The left forearm will take over, left hand will try to remove that focus. So it has a particular local sign. It is then secondly, causality is the reciprocal inhibition. The reciprocal inhibition is a very important property of this scratch reflex. Well, there is alternate contraction of antagonistic muscles. So this to and fro scratching occurs because of the contraction of antagonistic muscles. So there is alternate contraction and relaxation of the muscles of the limb, that is flexors and extensors, or adductors and abductors. So this pattern of alternate contraction and relaxation of antagonistic muscles, it depends upon the reciprocal inhibition followed by rebound, and this depends upon the oscillatory circuits in the spinal cord. So the reciprocal inhibition will cause alternate activation and then inhibition of the motor neurons in the spinal cord, controlling antagonistic group of muscles acting at a particular joint. That is, at a particular joint, when it is being used to scratch, first one group of muscles will contract, like suppose let us take an example, flexion will be occurring, then extension will occur, flexion will occur, then extension will occur. So when flexion occurs, extension is inhibited, then extension occurs, flexion is inhibited. So there is oscillation of these antagonistic contraction without depending upon the feedback impulses from the muscles or joint. So the reciprocal inhibition is an important property of this scratch reflex. Now the third property, that is the rebound. Now when the muscles are contracting, antagonistic muscles are contracting, suppose first the flexor muscle is contracting, now the extensor muscle is kept inhibited. Next, in sequence, the extensor will contract, but because of the rebound phenomena, it will show the higher magnitude of contraction. Now the flexor is inhibited. Next time the flexor will show a higher magnitude of contraction. So this is important. So in this case of stretch reflex, the local sign, reciprocal inhibition, rebound, these three properties play a very important role in the execution of the scratch reflex. This scratch reflex doesn't depend upon the peripheral impulses from the limb, and it has highly developed position sense because you want to remove the irritant focus. So you want to remove that irritant focus so as it will not cause damage to your body. So scratch reflex, everybody must have experienced that scratch reflex. Now you know the basic physiology of the scratch reflex. Now the next topic is the upper motor neuron lesion and lower motor neuron lesion. Basically difference between the two, that is how the upper motor neuron lesion differs from the lower motor neuron lesion. Now we will be studying the upper motor neurons in subsequent lectures, but you know what are the lower motor neurons. So first we should know what are the upper motor neurons and what are the lower motor neurons. Upper motor neurons are the neurons present in the motor cortex, all the pyramidal neurons, and the name is up, so they are present up, and the lower motor neurons are present in the cranial nerve nuclei as well as the alpha and the gamma motor neurons. So these are called as lower motor neurons. So now what are the lower motor neurons? Lower motor neurons are the alpha and gamma motor neurons as well as the cranial nerve nuclei, cranial neurons or cranial nerve neurons. These are the lower motor neuron, while the upper motor neuron are the neurons of the motor cortex. In the previous slide, we came to know what are the lower motor neurons and what are the upper motor neurons. We'll be studying in detail the upper motor neurons in subsequent sessions. Now, we should be able to know what is the difference between the disease affecting the lower motor neuron and the disease affecting the upper motor neuron, because it plays a very important role in the reflexes, as well as we are going to study the tone, the posture in subsequent lectures. So we should be able to be very clear how these lesions affect these reflexes, so that we'll be clearly able to study the posture and tone also. So first of all, talking of the neurons involved. The neurons involved in the lower motor neuron lesion will be the lower motor neuron. So what are the lower motor neuron? So lesion of alpha and gamma motor neurons, or of neurons of the cranial nerve, or the pathway involved in their distribution, leads to the lower motor neuron lesion or paralysis. I again repeat, the lesion of alpha and gamma motor neurons, neurons of cranial nerve, or the pathway involved in the distribution of these neurons will lead to lower motor neuron lesion or paralysis. While in the case of upper motor neuron, whenever there is lesion of the motor neurons other than the lower motor neurons, or the pathway involved in the distribution or the connection between the upper motor neuron or the lower motor neuron, we get the lesion which is called as upper motor neuron lesion. Now again, what is the upper motor neuron lesion? The lesions of motor neurons other than the lower motor neurons, or the pathway involved in the distribution or connection between the upper and the lower motor neuron. When it is deranged, disrupted or affected, it leads to upper motor neuron lesion or paralysis. Now the muscles involved, which are the group of muscles involved in the case of lower motor neuron lesion? In the case of lower motor neuron lesion, generally the group of muscles are not involved. It is either a single or individual muscles are affected generally, because it's most of the time it is localized. While in the case of upper motor neuron lesion, here group of muscles are generally affected, not the single individual group of individual muscles are affected. Then The causes of lower motor neuron lesion. What leads to lesion? So any disease affecting the lower motor neurons, or any disease affecting the pathway or causing obstruction, any tumor, any disruption or injury due to trauma. So there are multiple causes. I'll give you few, the important one. Motor neuron disease. So this is a group of diseases which the motor neurons are affected. Here the motor neuron disease can also affect the upper motor neuron also. Any peripheral neuropathy or diseases of the nerves, or poliomyelitis and spinal cord injury with nerve root compression. So any injury of the nerves, injury of the nuclei or neurons of the nerves, or in the injury in the spinal cord, interruption in the root of this will cause a lower motor neuron lesion. In the case of upper motor neuron lesion, again any condition which damages these neuron or disrupts the pathway of these neuron will lead to upper motor neuron lesion. So what are the common important causes? So tumors, whenever there is any tumor which is present in the brain, what it will do, it may not directly damage your neuron, but it becomes a space occupying lesion, because there is a fixed space in your cranium cavity, and then these tumors, they take up the space of the neurons, they may compress the neurons, so these are known as space occupying lesions. Then stroke. Stroke occurs whenever there is vascular injuries, whenever there is ischemia of the vessel supplying the particular part of the brain, or the blood supply to that particular part stops, so the function of those neurons is disrupted. Or amyotrophic lateral sclerosis, it is also one of the motor neuron disease. So all the conditions which affects the neuron lead to upper motor neuron lesion. There are multiple of them. I have written only few which are the common one. What type of paralysis will you see in the lower motor neuron lesion? Or you will see a flaccid paralysis. What do you mean by flaccid? Flaccid is that the muscles that do not have any tone. And the tone of the muscles, there is hypotonia. Because you know the tone is being maintained by the stretch reflex. Tone is maintained by the gamma efferents, by the stretch reflex. So these gamma neurons are affected. So or the alpha motor neurons are affected. So what will happen? So the tone cannot be maintained. There is hypotonia, and when there is no tone, the muscles become flaccid. So we have a flaccid paralysis in the case of lower motor neuron lesion with hypotonia. So then in the case of upper motor neuron lesion, we have the spastic type of paralysis. There is hypotonia. Why there is hypotonia? Why there is hypotonia? Because the tone is increased now. The gamma efferents, they become highly sensitive. The stretch reflex is sensitive because the upper motor neurons which were inhibiting the lower motor neurons, that control is lost. And what type of rigidity we observe? We observe the clasp type of rigidity. Initially there is resistance, which gives away, and we get a clasp type of rigidity. We already discussed that. So the paralysis seen in upper motor neuron lesion is spastic type of paralysis, and there is hypotonia. The tone is increased. So you remember, upper motor neuron lies up, so everything goes up. The tone goes up. Okay. Here also the lower motor neuron is lying low, so the tone goes down here. Now what happens to the muscles? Muscles, they show atrophy, or wasting of muscle occurs in the lower motor neuron lesions, because the nerve supply to the muscles is lost, and nerve supply, it is sort of trophic to the muscles. It is nutritive to the muscles, and this is lost. So there is wasting of the muscles. Muscles are not being used. So there is sort of disuse atrophy also. Then in the case of upper motor neuron, because the muscles here are not affected, because the muscles, the tone is there, so there is no atrophy. There might be weakness, especially the extensors are weaker than the flexors in the arm, but reverse is true in the legs. That is, in the legs, the flexors are weaker than the extensors. So atrophy or muscle wasting is seen in lower motor neuron paralysis, while no atrophy is seen in upper motor neuron lesion, but slight weakness can be there. Then reflexes. First of all, let us come to the deep tendon reflexes. deep tendon reflexes in lower motor neuron lesion, there is areflexia because there is no tone, no stretch reflex, no gamma efferents are not discharging. So they are totally absent. The deep tendon reflexes are totally absent, or there is areflexia. In the case of upper motor neuron lesion, because the stretch arc is maintained, stretch reflex is normal, so rather it is more sensitive, so there is hyperreflexia or exaggerated reflexes because of the loss of upper motor neuron inhibition. And so we can see that here the lower motor neuron low, it's low, so here the tone is low, the reflexes are low. Upper motor neuron lesion is up, so the tone is high, reflexes are high. So you can remember it. Now the superficial reflexes are completely lost in case of the lower motor neuron lesion, because though muscles are there, the muscle control is lost, so the superficial reflexes are lost. Here in the upper motor neuron lesion, again the superficial reflexes are lost, but here see the deep reflexes are present. They are exaggerated, but here they are absent. If you remember, the superficial reflexes, they are controlled by this upper motor neurons. They keep them in a facilitated state, so they are absent. So I again repeat, in the case of lower motor neuron, there is flaccid paralysis associated with hypotonia, wasting of muscles with areflexia of both the deep tendon as well as superficial reflexes, while in the case of upper motor neuron lesion, there is spastic paralysis with hypotonic muscles. There may be clasp knife rigidity and the muscles are not atrophic, but slight weakness of the muscles can be there with hyper exaggerated reflexes, hyperreflexia or exaggerated reflexes, and the superficial reflexes are absent. Now another very important sign which is seen in the case of upper motor neuron lesion is clonus. We already said clonus is repeated regular jerky movements of the muscle, and I previously told you that clonus is generally associated with hyperreflexia and hypertonia. So this is present in the case of upper motor neuron lesion while absent in the case of lower motor neuron lesion. Then another very important sign which is seen in the upper motor neuron lesion is the Babinski sign. So Babinski sign is positive in the upper motor neuron lesion, while it is not seen, it is negative, rather negative or absent uh, in the lower motor neuron lesion. Rather, there is no superficial reflexes present in the lower motor neuron. Here in the upper motor neuron lesion, all the superficial reflexes are absent, but the Babinski sign is positive. Plantar is extensor plantar here, and we also see that Gordon sign and all those signs are also positive. Hoffman sign is positive. There is another sign very important is pronator drift. Pronator drift, what is it? Pronator drift. So what you do is you ask the patient to stretch his arms fully in front of him or her, so with his palms facing upwards. So you tell the patient to stretch his arms fully with his palms upwards, and if the lesion is present, and when he or she, now you tell him to close his eyes, when he or she closes the eye, the affected side arm, it pronates due to difference in muscular tone. So I again repeat, in the pronated drift, you tell the patient to keep his arms stretched with the palms facing upwards and to close his or her eyes. When he closes the eyes, the affected arm, it pronates. So this is known as pronator drift. So this is seen in the upper motor neuron lesion. Then involuntary movements are seen in lower motor neuron lesion like fasciculations and fibrillations. These are seen just prior to atrophy. So once the muscle atrophies, then no fasciculation and fibrillation will be seen, while these are completely absent in the case of upper motor neuron lesions. Then when you try to do the electromyography or EMG for nerve conduction studies, there is decreased nerve conduction in the case of lower motor neuron, but no change in the upper motor neuron. That is, the nerve conduction is absolutely normal. But in the case of lower motor neuron lesion, it is decreased, and after some time it may completely be lost. So these are, again I repeat, lower motor neuron lesion, Clonus and Babinski sign is not there, but it is seen in the case of upper motor neuron lesion. Then involuntary movements fasciculation and fibrillation are seen in lower motor neuron lesion, which are absent in the upper motor neuron lesion, and in the lower motor neuron lesion the nerve conduction may be decreased, but in the case of upper motor neuron lesion there is no change in the nerve conduction. So now we have studied reflexes, all the different type of reflexes. What is a reflex? What are different types, or what are different type of classification? What is a reflex arc? What are the receptors, sensory receptors in the muscle spindle, Golgi tendon organ, how the muscle spindle plays role in the stretch reflex, what is the inverse stretch reflex, what is the function of Golgi tendon organ, how the muscles movements are carried out, what are the different properties of spinal reflexes, what are different type of spinal reflexes, what is flexor withdrawal reflex, cross extensor reflex, what is scratch reflex, and what are the clinical classification of reflexes like superficial reflexes, deep reflexes, pathological reflexes like Clonus signs, Clonus, Babinski sign, different. So we were studying like a physiology student. Now let us come out of this routine lecture class. Let me ask you a question. Why do we need reflexes? A layman comes to you, you are examining his reflexes, you are eliciting the reflexes, and he asks you that what you are doing. You tell him that I am eliciting a reflex, I am checking your reflexes are normal or not. So he tells, so what is the advantage of this checking? Why do you need to check reflexes? Why do I need reflexes? So even if they are defective, so what will happen? Why do I need reflexes? So how will you explain to them? So all humans and animals have reflexes to help us protect from danger and to carry out our routine activities. These reflexes are generally unconscious responses, and most of them operate at the spinal level or lower brain level. That is, you don't require the higher brain or the higher conscious to operate. So they are simply unconscious. Let us take an example. When you touch a sharp or hot object, what do? You immediately pull your hand without giving it a thought. This is a natural response of your body to a painful stimulus. So what you were trying to do? You were trying to protect yourself. Have you ever thought why? You did not think. You never thought. You just pulled your hand away because you wanted to protect yourself. You didn't want to burn or prick yourself. So it is a reflex. So most of the reflexes occur in a day-to-day activity without the involvement of brain. That is, without any conscious thinking. Suppose you are going to write, or you are going to copy note. You are going to play a game in a laptop or a computer. You thought about it. You planned it, and then you do. That is your conscious involvement. That we cannot call a reflex exactly. But the reflexes which occur in day-to-day activities routinely without your conscious perception, they become important part of your life. Many reflexes are even faster than the blink of your eye. What they do? They help you to keep safe. This is very, very important. That is, they're important for natural survival capacity. They help you to stand upright, to be active, help in maintaining the posture and position. They help to maintain the homeostasis, maintenance of movement. You walk with the help of these reflexes. Initially, you start and then you walk. You think and then you start walking. And sometimes you keep on walking, like you started when you kept on walking. So again the reflex. The brain can what do? They can modify, brain can modify and fine tune the reflex actions. For example, imagine a situation. Let us take a situation. You are walking. Then suddenly you trip and you start falling. What your hands and arm will do? they will try to break your fall and protect you, as most of your body's muscles will start contracting to minimize the injury. So the here reflex have come into picture to protect you. Suppose when you are tripping, you are holding a glass item in your hand. While falling, what you will do? Within 10 to 30 milliseconds of tripping, your conscious motor centers will help you to modify the fall, weighing the importance of that glass item or your body. It will try to compare the importance of that glass item and your body, and accordingly you may try to protect the glass or your body. Here what did the brain do? It modified your reflex action. So this is important aspect of your natural survival capacity. Now you are clear that reflexes protect you. Then reflexes, they maintain your posture and position. So when you stand for some time, your quadriceps muscle, you are standing with your knee extended, they start fatigue, show fatigue. So what will happen now? But you are standing, the stretch is being maintained, so the muscle spindles are excited, they will again send impulses to the quadriceps muscle, and you will not fall down. So recovery of position occurs and the posture is maintained and your body position is maintained. You are sitting, again your body's tone is maintained. You are writing, your tone is maintained, the reflex. Then more important is that we can modify the reaction time of reflexes with practice also. Some people have a short reflex time, that is they have a rapid response rate, but some people do not have. But with practice we can change this reflex rate also. Then maintenance of homeostasis. So we have studied homeostasis in our initial lectures of general physiology. What we said that different visceral reflexes, they play an important role in homeostasis. So what are they? They are again reflexes. So all those visceral reflexes, they have a very important role in control of or maintaining the homeostasis, like blood pressure reflex, the swallowing reflex, the deglutition reflex, the micturition reflex, the defecation reflex, and moreover the movements. Again, the movements are being operated because of reflexes. Now next time when you walk or when you are sitting, just imagine, how do you sit? Why do you are sitting? Who is maintaining the tone? Your hands are not lying limp. When you're standing, you're not walking, you're just standing. How the tone is being maintained? All your muscles throughout your body, the stretch reflex operating throughout your body while you're standing, in your neck, in your head, in your arms, leg, spinal column. So you are standing upright. So any part is affected, the posture is affected. So your blood pressure is maintained, your temperature is being maintained, you are being protected, you fall down, you touch a hot object, you insect crawls, what you do, you try to remove the insect, you get a pin prick, you try to remove your hand from that pin prick damage. A thorn pricks your hand, you try to remove your hand from the thorn. So the reflexes are occurring in day-to-day activity. So next time whenever you are active, you are sitting, always keep revising why you are doing so. So we finished these presentations of reflexes. So soon I'll be giving you another presentation in which we'll be studying the spinal cord injuries, spinal cord abnormalities. We know about the spinal cord. Most of the motor activity of the spinal cord we know. The sensory part of the spinal cord we know. The structure of the spinal cord we know. The reflexes operating the spinal cord will be studying the abnormalities of the spinal cord. The sensory we have already studied. Now collectively we'll be studying what is spinal cord injury, what happens during spinal cord injury. So thank you and goodbye.